From the BMJ in London. I'm Fiona Godley, Editor-in-Chief, and I have with me my colleague, Dr. Helen MacDonald, Clinical Editor on the BMJ. We're really delighted to have half an hour of this global live stream on innovations in healthcare. I'm going to begin with a quick summary of what the BMJ is trying to do, and then I'm going to ask Helen to give us some detail on one particular innovation, which is our attempt to improve partnership with patients in the way healthcare is delivered. So briefly, first of all, though, about the BMJ. We have an aim to improve medicine and research. Our aim is to help doctors make better decisions, to promote partnership with patients, and to help create a healthier world. And the way that we do this is by publishing a rather unique mix of research, education, academic comment, and increasingly journalism, including investigative journalism. We have, I think, been innovative over the years with various initiatives, increasingly pushing towards greater transparency in healthcare, greater transparency in the publication of research. So we are an open access journal for the research, and we have open peer review, including publication of the full pre-publication history of all of our research articles. In addition, we have become more campaigning as a journal over the years, and we have a number of specific campaigns that we are pursuing. We're pursuing a campaign for access to clinical trial data to improve the accountability and reproducibility of research. We have a continuing campaign to try to pull back the excesses of medical enthusiasm. So we call it our Too Much Medicine campaign, which looks at ways in which medicine has overstepped itself with medicalization of normal life, but also with expanding definitions of illness and new technologies that tend to find problems that we don't yet know how to deal with. And we also have a campaign around integrity and anti-corruption in research and healthcare, and that looks at issues such as conflict of interest and bias caused by academic or commercial influences. And the aim of these campaigns is really, I think, without wanting to be too ambitious about them, they are to try to change the culture of healthcare. And the campaign that Lucian wanted us to talk about particularly was our patient partnership campaign, and that really is about changing the culture. The inspiration behind our particular initiative has been Dr. Tessa Richards, who is a colleague of ours, who is herself not only a doctor, both general practice and physician-trained doctor, but she's also herself been a patient and the carer of a patient. And she has been extremely persistent and effective in making us all, as editors, to understand that patient care, or patients at the centre of care, is the only way to deliver high-quality healthcare. And we're very lucky also to have a patient editor on our staff, Rosamond Snow, who has been pushing forward on a whole host of initiatives that Helen is about to describe to you. Neither Tessa nor Rosamond can be with us, so we're sort of really proxies for both of them. Briefly, before I hand over to Helen about our patient partnership campaign and initiative, we have recruited a patient panel, an international patient panel, who have been keeping us very much on our toes, not allowing us to be complacent in the least about what we've achieved so far. I think we have achieved a few things, pushing us forward all the time. We have a patient partnership strategy, which they've helped to create and are keeping us moving forward on. We launched this in May 2013 with this editorial. I don't know if you can see that cover, which says, "Let the patient revolution begin," which we wrote with Victor Montori, and really tried to lay out why we're doing this and what we hope to achieve. We've published a collection of articles called a Spotlight. So I don't know if this will show, but if you go to bmj.com /patient-spotlight, you'll see a whole collection of articles about patient partnership and shared decision making. And we have also got the campaign page called Partnering with Patients on. This is very low technology sharing of our stuff here, but patient partnership is Partnering with Patients is the campaign page where you'll find the materials we've produced so far. So in handing over to Helen, let me just say one thing. We want to improve the quality of our content so that it reflects the need to share decisions with patients, the need to put patients as co-creators of their healthcare. But we also wanted to walk the walk ourselves, and that has meant changing our own processes and improving the way in which we do peer review and commissioning and editing of content. And so that's really what I think Helen will now tell us about. Over to you, Helen.
Thanks, Fee. And hi, everyone. It's really a pleasure to talk to you today about our policy, which we think is quite innovative. And as a journal, as a peer review journal, that was an obvious place to start for us in trying to innovate and involve patients in our work. And we now try and review all of our research articles and a lot of our other content, particularly education articles, to patients as we would scientifically peer review them to our colleagues. And we're doing quite well, and it seems that it's quite feasible and realistic to do it. So we've now got about 500 patients signed up on our review bank. And last year, of the people that we asked, the patients and carers that we asked to give a review of an article or research paper of some type, about 60% of them agreed to review it, which is better than academic peer reviewers. Only about 42% of them agree. And in terms of timescale, it works out quite favourably. Patients take about 8 or 9 days to decide whether they're going to do it and deliver it in about 10 days to the editor for us to consider. And that's pretty comparable with academic reviewers. So that's one thing that we've started to do. And to do that, we've had to think about really what we're asking patients to do and what we're asking peer reviewers to do, and to write specific instructions for patients on how they can best help us to make decisions about articles, and to invite them to tell us what really matters to them to improve their health, and whether the content that we're considering is likely to help their doctors do that. We're divided into sections at the journal, and each little team is working hard to try and involve patients better. So I'm going to start by telling you some of the things that the research team are up to. And one thing we've asked people to do with respect to research papers is to report how patients have been involved in the research that they've submitted to us. And what that means is that we ask them to include a box, a bit like a conflict of interest statement box that would appear in their article, which tells us how patients have been involved, and also tells us if they've not been involved. And we're certainly finding that there's a lot of research out there which hasn't involved patients at all. And we're asking authors now of meta-analyses studies to do a sensitivity analysis to include those studies which have involved patients in the primary research. So those are some baby steps research are taking. Elsewhere in the journal, as Fee said, we publish comment articles and education articles, and we've started a new type of article called What Your Patient is Thinking. And this is edited by our patient editor, Rosamond, and the authorship is entirely patients. There is no doctor interference. So the patients set the scope of what they talk about, and more importantly, they set the scope of what they ask doctors to reflect on. So at the end of each of these articles, there's 3 questions that the patient and Rosamond concoct to ask the doctor to reflect on their own performance, to reflect on the performance of their service or their hospital that they work in, and ask them to say how they might change how they behave as a result of having read that article. And we're getting some interesting articles in, and we're getting some good feedback from them. So we're trying to reach patient voices that might otherwise not be heard. So those drug users, people who've been in social care or refugees. We've had some feedback on articles that we've published on what it was like to experience a miscarriage, and that's led to changes in how people have organised their hospital departments. It's also been used for teaching medical students. And Rosamond's had really nice emails back from some of our authors saying that it's empowered them to go back to their doctor with the article that they've published in the BMJ and say, I have never had the courage to say, I didn't really like what was going on here, but read this and this is what I'm really thinking. And those articles sit in the education section of the journal, and elsewhere in the education section, we've been trying to involve stronger patient voice. And again, that's happened in a number of ways. Like the research section, we've asked authors to tell us how patients have been involved in the creation of their article. And we asked them to report that quite specifically. So we asked them to say who they asked and why they asked those people, what was the expertise of those patients and what did they say? And most importantly, how did you actually change your article as a result of what they said? And through that method, we've had some mixed results. We've had some really successful articles. We had a clinical review on diabetic ketoacidosis. And those authors came up with a really interesting way of involving patients. So they went onto a diabetic forum and they had a live tweet conversation with patients posting there about what they wanted to know about DKA and what their doctors perhaps should know about DKA. And that informed how the article was structured and the content that was there. We've also had a clinical review that was co-authored by a patient who had gone through something called the Daphne program for supporting self-management in diabetes, and that's been very well received as well. But it's not all plain sailing. This is a big change in how authors work, in how we work, and there are some risks. It's difficult sometimes to help authors decide which patients to choose, whether to choose patients that they are not involved in the care of or to ask their own patients, which has its own risk for their relationship with their patients. We've had difficulties knowing always what to ask the patients and how to empower them to go off-piste and totally blindside us and tell us what we just never thought of or give us a perspective that they haven't felt empowered to give. We've had difficulties finding patients who might tell us what it's like to have a symptom rather than a disease or an illness that comes and goes very quickly, because there aren't big patient communities built up around what it's like to have a cough or what it's like to have a cold. And it is challenging to reach hard to reach groups, so people who don't necessarily speak the same language, and hard to work out how we reward or say thank you to patients, whether we pay them because we don't pay our clinical authors. So those are just some immediate thoughts that we put together for you, and I'll hand back to Fee to tell you some more.
Thanks very much, Helen. I think, just to reiterate, we see this very much as an intervention, both for our own processes, but also how this appears to the readership, and our readership is doctors around the world, and not patients specifically. That's one of the issues we try and struggle with. We want patients to help us make content that is better for doctors, to improve the way doctors behave and the amount of partnership they create with their patients. And so the initiative that Helen mentioned about asking researchers whether they've involved patients in their research is very interesting, because the statements we now include on every research paper, which says, how did you involve patients in this research, often reads rather starkly. And we've had readers come back to us and say, well, why are you publishing research which actually says we did not involve patients in this research, we did not involve them in the analysis, we have no plans to disseminate this research to the participants in the study. And it comes across very weirdly, and people think, well, this is very bad research. But what that really is saying is this is the norm, and we want to expose that as the norm and then begin to say to people, this isn't okay. And the next step in the intervention will be to say, you've told us that you didn't include patients. In future, we don't want to publish research where patients were not involved at every stage. So what I'm hoping is that in a year or two's time, when we've seeded the thought, if you like, or helped to seed the thought along with help from so many people around the world, that we'll be able to then close the door on research that doesn't do this from the outset. And I think the same is true for the education work we're producing, that the idea of having authors who are patients, having them co-create the content with the clinicians and scientists, is that in future it will become the norm, and we won't want to publish research, educational content that hasn't had a patient as a co-author from the outset. And we see, as Helen described, that one on diabetic ketoacidosis, we see how that changes the quality and the tone of the content itself. I think one of the challenges we face is, as Helen has said, resources. We can't pay patients, we don't pay our non-patient authors, and we don't have a sort of budget that would extend to that. But they're giving of their time in a way that clinicians and academics are paid to do and the patients aren't paid to do. And this becomes particularly difficult as an issue when we want to include patients in conferences and they're giving of their time and they're travelling to the conference and they haven't got the funding to do that. And I know that will be an issue that is faced by other people as well. We haven't really resolved that, but we are going to have to start budgeting. If we want patients to be really involved in our conferences around the world, we're going to have to start budgeting for that. The other issue that's come up is conflicts of interest. The types of conflicts of interest that doctors and academics have are very different to those that patients might have, but some of them may well have been involved in may have had funding from drug companies, which can be problematic for us. Or they may have hidden conflicts about their views of a particular drug produced by a particular drug company because they've either had a good experience on it or they've had a bad experience on it. And those are the sorts of conflicts that we might not have otherwise thought to ask about. And exactly how we navigate that, I think, is going to be very interesting for the future. We've been very grateful to Radboud Nijmegen for giving us a huge honour of this Patients Included. I've even brought it with me, and Lucien, if you're there, you might like to know. I brought it with it. We framed it, Patients Included Award 2014. We, as far as we know, are the first journal to have been given that, and it's something we prize very much. We have it on our website, but we also recognise that we've got a lot to do to really continue to deserve that award. And one of the issues has been this issue about involving patients in our conferences and trying to come up with a set of criteria, a set of targets that would allow a conference to be genuinely seen to have included patients in it. And that, in our mind, would include patients being involved in the beginning, right from the start, the planning of the conference, the strategic steering of the conference, then the programme, and then the delivery, and then the feedback. And I think we have made some inroads, but it's a huge challenge and one that we continue to realise we need to be prompted and prodded and made to do better on. The other issue that comes up for us is around who is our target audience. And as we get more and more involved in patients taking part in the journal, there is this cry, is the journal for patients as well as doctors? And that creates business model problems for us in that our business model is a subscription-based model. Libraries purchase subscriptions on behalf of their communities of academics and doctors, or the journal goes out to doctors in a print form funded by pharmaceutical advertising. The membership of the BMA receives the print journal as well as the online. So we have a model that is a mix, but it's aimed at clinicians and academics. And we cannot, as a business, as a company, as a publishing company, afford to make the content completely free, which is what it would need to be to really reach patients as a community of readers. And so that's a tension that we still have difficulty navigating. The other thing I want to talk about it briefly before we finish is about evaluation of what we're doing, because clearly this is a new initiative. It has a number of streams. We're very lucky at the BMJ to have a researcher on our staff, Sarah Schroeter, who has been helping us over the years look at ourselves and evaluate what we do. And Sarah is leading a number of research projects relating to this patient partnership strategy. We're looking at the feasibility. How feasible is it to have patient peer reviewers? What are the problems we face? What additional time does it cause us to spend? What are the additional costs? But we're also looking at the impact, and that is, does it change the content? Does it change the decisions? How do authors respond to finding themselves being confronted with feedback from patients that may not have been something they expected? Do they change their content as a result? Whether we can find out about evaluation of the impact on the culture of healthcare, I think that's going to be a big stretch, but we would welcome any thoughts or feedback that you might have for how we could improve on that. We're looking also for funding for that research. So anyone out there who would like to help us fund the evaluation of our patient partnership strategy, we'd be very, very pleased to hear from you. I think that really is it from us on that. We would, as I've said, really like to get your feedback. We continue to seek partners in this work. It's been great to work with Lucien and colleagues at Radboud. We're in touch with PCORI in America, looking at their work on patient-centered research. Really just sharing ideas. We're not a formal partnership there, but really looking for people who are working in the same area and who can give us ideas or encouragement. Sometimes this can seem quite hard to get right, and we'd welcome input from that. Our most recent contribution to the debate has been an article published this week which challenges the guideline movement, in particular, to produce better resources for patient and doctors' shared decision-making. It makes the point that doctors are finding this difficult. We haven't got the right tools. The guidelines are mono-disease-orientated, single disease-orientated. Healthcare isn't like that. The guidelines are very text-based. We need interactive tools to help with really evidence-based shared decision-making. So that's just to let you know, if you want to go and read that article and give us your comments on it, we'd really like to hear from you. We want to continue to innovate on the journal. We want to have ideas from our international community about how we can do that. And so this is a great opportunity to connect with you all. I hope the conference goes really well and that the global live stream is a great success. Thank you for including us in it. Thanks a lot. Bye-bye.